Thank you, Florian, and the organizers for your very kind invitation. This is exactly the sort of meeting that MASC supports, and we had a meeting this morning talking about the Italian group, the German group, AFSOS, and I think it's extremely important with this particular meeting to get an idea of what our colleagues are doing across the ocean as well, because if we have to sit down and discuss guidelines, the first thing is always to understand the perspective from another side. I'm particularly amused because I'm actually a Canadian imitating an American for the purposes of this talk. I'm going to go over some of the facts about palonosetron, which is not so widely used here. I'll address the question of why might this audience care about an American perspective and an old drug like palonosetron that was approved by the FDA 11 years ago. Why has palonosetron dominated the 5-HT3 receptor antagonist market in the United States despite its high cost? And what does the combination, just very briefly, of palonosetron and natupinant offer? Because you're going to hear more about that. This was just received FDA approval in mid-October. I'll refer to it as NEPA, but that is not the brand name, but that's what appears in the articles. So palonosetron is a cetron with a very long half-life compared to ondansetron and granisetron. It's the only 5-HT3 receptor antagonist without an FDA safety warning about QTc interval prolongation. Advocates of granisetron could criticize that because there isn't much of a difference in the safety margin between granisetron and palonosetron in terms of QT interval prolongation. The oral version was never marketed in the United States, although it is available in Canada and a number of other countries. And the National Comprehensive Cancer Network lists that as the preferred 5-HT3 receptor antagonist for highly and moderately emetogenic chemotherapy. It's the leading 5-HT3 receptor antagonist in the United States, despite a listed cost that's higher than aprepitant. And it has, I saw on one website, an estimated 50% market share in the US. So it is the dominant 5-HT3 receptor antagonist. So why care about a USA perspective? Well, I think it relates to the NCCN guidelines, which when I go to India or the Middle East, where I am now visiting, they use NCCN guidelines. They endorse palonosetron, and this influences oncologists around the world. Their guidelines are easy to apply. They can be criticized for not being so evidence-based, but they are comprehensive, and importantly, it's not just supportive care guidelines, it's also anti-cancer treatment guidelines, which really catches the eye of the medical oncologists. And many oncologists have been trained in the United States, so it has widespread impact. Now, from an economic point of view, historically, the market in the USA has been about half of the global 5-HT3 receptor antagonist market. Now, the United States is an unusual market. There is freedom to prescribe, unlike some other countries where we're constrained by funding, and it is wealthy enough to actually do that for an appreciable portion of the population. There are incentives to prescribe expensive intravenous drugs, at least in outpatient clinics. And in the US, there's actually a very large use of palonosetron in the preoperative setting. It's about 35% of the US market. And I'm not sure the economics behind that, but in the reports to the FDA about QTc interval prolongation, quite a number of them dealt with the perioperative setting. Now, the patent expiry in North America, very interestingly, is 2024. it received a major prolongation. So palonosetron is going to be around for quite a while. It's the same, Canada, I don't know, in Europe. Now, I always like to rely on evidence, and this very busy slide is a meta-analysis that came from our group. Marko Popovic presented this at MASC in Miami, and in this forest plot, you see that all of the dots from the 8 double-blind randomized trials lie to the right of 1, favoring palonosetron over granisetron over ondansetron. And the p-value there was highly statistically significant, but the more relevant question is, what is the absolute difference in nausea and vomiting? What is the absolute superiority? Here is a horribly complicated table from the article. We had a very enthusiastic junior investigator who loved all sorts of relationships, looking at them statistically, but the ones that are really of relevance in that table is, what is the difference between palonosetron and ondansetron or granisetron in vomiting over the first 5 days or in the absence of nausea? And it turns out that for both, it was about an absolute 10%, highly statistically significant. So palonosetron is superior, and this isn't simply due to its longer half-life. I'll come back to this in a moment, why that could explain much of the difference, in that there was still a statistically significant, though smaller, difference in the first 24 hours favoring palonosetron. There was relatively slow uptake of palonosetron in the guidelines, particularly in MASC, but also in ASCO as the preferred cetron. And that's because only one of those randomized trials allowed the use of dexamethasone. Didn't mandate it, but allowed the use of dexamethasone, and none contained aprepitant, so that there wasn't what we would consider as a standard therapy arm. It was a single day of, say, ondansetron versus a single day of palonosetron. Another meta-analysis before the era of palonosetron found that if you gave dexamethasone on day 1 and continued it beyond day 1, that continuing beyond day 1 conferred benefit. An extra 8 patients out of 100 did not vomit. So, sorry, let me rephrase that. In the studies, dexamethasone was given on day 1, and the randomization was to a cetron or not beyond day 1. And the difference there was about 8 patients out of 100 with vomiting. So if the benefits of palonosetron are 10%, day 1 palonosetron compared to, say, day 1 granisetron or ondansetron, perhaps you could have improved the results by another 8% by allowing ondansetron on day 2, 3, 4, 5. So that's been the criticism. Now, that's a relatively sophisticated argument, and the studies that are published as statistically significant differences. So was palonosetron successful in the USA because oncologists actually read antiemetic trials? I think if I asked you to raise your hands, most oncologists, at least in a general audience, would say they've never read a single antiemetic trial. So I say that's not likely. I think the United States reimbursement scheme is complicated, and Dr. Gralla will undoubtedly correct any inaccuracies. But if you look at the Medicare and Medicaid system, there is a $20 administration fee for palonosetron, an intravenous drug. Medicare also allows an additional 6% difference between something called the average sales price and it allows that 6% markup over the average sales price. So you make about $31 every time you inject palonosetron, as opposed to nothing for administering oral ondansetron. So for outpatients, there is an incentive to prescribe this more expensive cetron as compared to an inexpensive oral one. And there's also some effective marketing. I don't know if any of you have seen a picture like this in either the Journal of Clinical Oncology or journals around the world, a very eye-catching set of advertisements. And there are also fears of dexamethasone that a recent article really addressed. There are many patients who do not get dexamethasone beyond day one, and if you speak with the physicians, they say they are afraid of weight gain, insomnia, bone loss. And there actually are some data suggesting that, at least with palonosetron, you may not need to give dexamethasone beyond day one. There were 2 randomized trials looking at that, one led by Professor Apro and another by Professor Chelio, and a combined analysis concluded that there was no benefit to giving dexamethasone beyond day one for women receiving breast cancer chemotherapy with an anthracycline and cyclophosphamide. Now, as a comment, I would say that the evidence for dexamethasone beyond day one is by far the strongest for cisplatin, and whether any chemotherapy other than that benefits much from dexamethasone is less clear. So whether that's a palonosetron specific benefit or really it's an observation that most chemotherapies don't benefit is unclear. There was also an attempt for a while to say, well, maybe palonosetron is better because it's already acting by substance P. And there was an in vitro and in vivo study, this was not an Antiemetic study, suggesting palonosetron crosstalk with substance P. And there were no published clinical trials to address whether palonosetron added to aprepitant was helpful, because if they did overlap, then you might see very little benefit when you added palonosetron to an NK1 receptor antagonist. There were mixed results in a hospital and population series, a tiny positive result in an as yet unpublished clinical trial in cisplatin where palonosetron added, I think it was about 4 or 5% to the absolute response rate achieved with aprepitant and dexamethasone and ondansetron. A randomized trial, however, there have been a couple of ones recently evaluating the role of adding nitupetant, a new NK1 receptor antagonist, to palonosetron, and that's referred to as NEPA, approved just last month, in the setting of high-dose cisplatin and multiple-day dexamethasone. So this is a true test of whether the NK1 receptor antagonist adds to palonosetron. We don't have much evidence whether palonosetron offers more than ondansetron when an NK1 receptor antagonist is given. So this was a study by Paul Hesketh, an American, 694 patients randomized to 5 different arms, one of which was exploratory. And what I'm going to do is focus only on 2 arms, because one would be a standard palonosetron type arm with dexamethasone on several days and palonosetron this time given orally on day 1. And the other is the FDA-approved combination of the NK1 receptor antagonist nitupetant plus the 5-HT3 receptor antagonist palonosetron. This is 1 capsule, and this is the FDA-approved dose. The other arms were lower doses of nitupetant. And so if you drill down on the results, what you see is about a 15% absolute benefit in terms of the primary endpoint, as well as about a 15% improvement in the risk of vomiting, and interestingly also an improvement in nausea of about 10%. Now, some might look at that and say, well, didn't the aprepitant studies show an absolute 20% benefit? And that's true, but the control of vomiting in the standard arm, palonosetron plus dexamethasone, was much better than in the aprepitant studies where it was ondansetron or granisetron and dexamethasone. So the standard arm, as you can see on the left, had control rates of 75%, whereas in the aprepitant studies, they tended to be more in the range of 50 to 60%. So there was less room for benefit. So an NK1 receptor antagonist does add to palonosetron. It's not that palonosetron is a combination in itself of an NK1 receptor antagonist and a 5-HT3 receptor antagonist. Now, does having the resources, as in the US, to prescribe expensive antiemetics and a popular NCCN guideline translate into better antiemetic prescriptions? And that's not necessarily, and I'm going to give two dramatically different examples. One was a study by Hatoum using a USA insurance database where they had about 100 insurance plans over years when aprepitant had been approved a couple of years before as indicated for the therapies I'm going to talk about. And they have billing codes for the type of cancer, the type of chemotherapy, the antiemetics, whether there was a visit to the emergency department for nausea, vomiting, or dehydration in the 30 days following chemotherapy. And in this particular study, it was about 38% of the breast cancer patients who received palonosetron, and 23% of the cisplatin patients received palonosetron. Keep those figures in mind when we come to another study, because it's changed over the last couple of years. There were fewer emergency department visits for those patients who received palonosetron, statistically significant, but did patients get the best standard therapy? And the answer is no. This graph illustrates the various combinations of antiemetics that were used for breast cancer chemotherapy with an anthracycline and cyclophosphamide. And on the extreme, in terms of minimalism, there was a cetron alone. And at the other end was guideline, or at least close to guideline, recommended therapy with at least day 1 dexamethasone, a 5-HT3 receptor antagonist, and aprepitant. And what you see here is that 68% of patients did not get aprepitant, and 55% did not get dexamethasone. So this was actually not very good antiemetic therapy. Now, you might think that that's because of the perception that this does not cause a lot of nausea and vomiting, and it would be different with cisplatin. Well, that's incorrect. This is a different slide, but about the same size boxes. And what you see is 60% did not get dexamethasone, and 68% did not get aprepitant. And not surprisingly, 20% of patients had visits to the emergency department because of nausea, vomiting, or dehydration, which should be unacceptable. I'm going to contrast that with a more recently published study called INSPIRE. And this was an observational study, prospective, within 4 oncology practice networks, just a little later in time than the previous one, 1,292 patients, and they evaluated the antiemetics according to the most liberal interpretation of what's the minimum standard for antiemetics by the NCCN. And not surprisingly, as with the European study, NCCN guideline compliant therapy, at least by their definition, was associated with significantly better control of vomiting. Palonosetron here was the most common 5-HT3 receptor antagonist. The other cetrons virtually did not exist. 90.7% of the patients receiving highly emetogenic chemotherapy, mainly cisplatin, but also some breast cancer chemotherapy, had that triple therapy. Perfect. 73% of the moderately emetogenic chemotherapies, irinotecan, oxaliplatin, carboplatin, also received triple therapy. Now, we would never do that in Canada. So quite a contrast. So in summary, palonosetron has been commercially extremely successful and will be so for, I think, several years due to a favorable reimbursement scheme, somewhat superior results in clinical trials that may or may not have been due to trial design, and consequent adoption by a very influential guideline, some supportive results from the healthcare utilization literature, some very skillful marketing. I think practice in the United States, as you saw from the first reference by Hatum, as in many other countries, does not necessarily reflect guidelines. And there's considerable heterogeneity. There's no such thing as an American or Canadian approach to prescribing antiemetics. So I'd like to thank you for your attention, and as with Florian, welcome to Copenhagen, I hope. Thank you.
C'est d'échanger un peu après chaque sujet pour garder un temps d'interactivité. Est-ce qu'il y a une ou deux questions dans la salle? Lydia.
I'd like to ask you a question. As I was listening to your talk, I was wondering if perhaps there are patient factors that we haven't addressed, and if there's any role in your mind for studies that would combine some form of mind-body intervention to address issues such as anticipatory nausea, the response to nausea, that could possibly help and might even have the same beneficial effect as a good drug. We've all been impressed with patients who have nausea earlier and earlier during the course of treatment. I remember a patient who would just throw up when she saw me, even before anybody even put an IV, just because of the thoughts that were triggered. So is there a role for anxiolytics, for mind-body interventions, for combination therapies that really address the psychological aspects of nausea?
The best work in that area was, I guess, through Gary Morrow with his work on desensitization therapy, and it showed for vomiting both pre- and post-chemotherapy in patients who had anticipatory nausea and vomiting. It did help. The work with stimulation bands for acupuncture didn't turn out very successfully. There was work with ginger that showed a statistically significant difference on day one, only in nausea, only with one dose level of ginger that was started 2 days before chemo, and it was a very, very small difference. So there may be a role, but there's not a strong basis in evidence to individualize therapy, particularly from cycle one, and I think that's been part of the problem, that therapy has been individualized. For example, we allowed a choice before about whether to use a aprepitant or a non-containing aprepitant in an electronic order. Well, we found that we were able to get access to aprepitant for 100% of patients. So I said, take away the other option, because I noticed that physicians were sometimes ordering it when they didn't need to. So there may be a role for whether it's hydration, lorazepam, or other ones, but they haven't been well established in evidence, so they don't really appear in the MASS guidelines, although some aspects do appear in the NCCN guidelines as plus or minus.
Est-il une question? On a vu à travers l'une des études qui avait été présentée qu'en utilisant les drogues efficaces, on arrivait avec 20% de réduction de passage aux urgences. Enfin, on peut extrapoler la donnée. En France, le produit Palonosetron est autorisé depuis 1 an. Il n'est pas utilisé puisque, en termes de prix, il coûte 20 fois plus de 20 fois plus que le l'ondansetron qui est génériqué. Est-ce que c'est le même problème aux États-Unis? Comment faire? Est-ce qu'en France, nous devrions aussi réaliser des études coût-économie, médico-économiques, de façon à démontrer l'impact sur le retour des patients aux urgences ou sur les complications?
I think the first thing is to look at whether you're doing the best with the agents that are in popular use. As far as dexamethasone, is it being routinely used? For the high-dose cisplatin patients in particular, is it being used beyond day one? Is aprepitant being used in the right population? The unknown, but which has been helpful in our practice because in our province, palonosetron is not funded, so it's awkward to get. There is an increasing rate of prescription of olanzapine, which in 4 randomized trials has shown an enormous difference, albeit in a dose that probably you or I would not wish to take. And no one has evaluated, well, there's just one Japanese study that's evaluated 5 milligrams. But I think olanzapine will be a good supplement instead of the traditional metoclopramide and prochlorperazine, but we're not quite there in terms of the evidence, particularly at lower doses. So I think you could do the studies and repeat them. Your model might or might not show differences in emergency department visits. I guess that would be somewhat compelling. The first thing, though, is to get the basic antiemetics right in everyone and then worry about the fine-tuning later, because I regard palonosetron as fine-tuning.